Hi, my name is Olivia Bailey. My project is titled Machine Learning Analysis of Asthma Rate Predictors Across New York City's Community Districts. Asthma is a long-term disease that is defined as a chronic inflammation and narrowing of airways in the lungs. The Centers for Disease Control and Prevention estimates that 25 million people, or 1 in 12, have asthma in the United States. There is no cure. Unmanaged asthma has negative societal impacts. According to the United States Environmental Protection Agency, the annual economic cost of asthma in 2013, including medical costs and lost school and work days, amounted to more than $81.9 billion. In addition, asthma is the cause of 1/4 of all emergency room visits each year in the United States. Nearly half, or 44%, of all asthma hospitalizations are for children. Finding ways to control asthma is a national priority. My research goal is determining the significant predictors of pediatric asthma emergency room visits. To do this, data from New York City was utilized. New York City is composed of 5 boroughs: Brooklyn, Bronx, Manhattan, Queens, and Staten Island. These boroughs can be further broken down into 59 community districts. According to the New York Department of Health, pediatric asthma emergency room visits per 10,000 children for these 59 community districts in 2015 ranged from a low of 28 for Manhattan Community District 1 to a high of 647 for Bronx Community District 1. To understand these discrepancies, a linear regression model was created using publicly available datasets. It was hypothesized that the model would show that higher pediatric asthma emergency room occurrences will be associated with poor housing quality, higher percentage of Blacks in population, higher traffic levels, and higher percentage of adult smokers. The first step in the model creation was data collection. My dependent variable was pediatric asthma emergency room visits per 10,000 children for these 59 community districts. In addition, I created 33 independent variables using publicly available databases containing demographic, socioeconomic conditions, neighborhood conditions, and healthy living data. All the data was inputted into an Excel spreadsheet. This slide shows some of the spreadsheet. Python was used to create a linear regression model, and the model used this data. First, a histogram was generated of the dependent variable. Because the dependent variable was right skewed, it was changed to a natural log of child asthma emergency department visits. This improved the skewness. The next step was to build off the research paper entitled Multi-Level Socioeconomic Contributors to Childhood Asthma in New York City, a cluster analysis. In this paper, the researchers found a relationship between housing conditions and the exacerbation of asthma symptoms. To build off this research, principal component analysis, or PCA, was used to create a baseline model focusing on poor housing conditions. Specifically, PCA was used on the data for percent of renter-occupied homes without maintenance defects and percent of households prone to cockroaches. The first principal component, or PC1, of this analysis explained 92% of the variance. Therefore, PC1 was used in the model. A linear regression was created using only PC1. The data was randomly split using a test/train split, with 44 in the train and 15 in the test groups. Root mean square error and R-squared calculations were done on both the test and train sets. The initial regression of using PC1 resulted in a baseline performance of a root mean square error of 0.519 for the train set and 0.560 for the test set. Similarly, the initial regression had a R-squared value of 0.602 for the train and 0.598 for the test set. To improve the accuracy of the model, each independent variable, excluding PC1, was then individually analyzed. Each independent variable was added to the model, and a comparison of the root mean square error and R-squared from the new model and the old model were compared. If the variable was deemed to improve the model, a correlation matrix was then used in Excel to check for potential multicollinearity. As long as the new variable did not have high correlation with the current independent variable in the model, it was added. The final model had a good train/test root mean square error result. The root mean square error of the train set was 0.311, and the root mean square error of the test set was 0.348. Since the root mean square errors and R-squares are so close in value, the model is not overfitting. In addition, these values are an improvement over the root mean square error values in the baseline model. The R-square values are similar and an improvement over the baseline model. The R-square value of 0.857 shows that the final model explains 85.7% of variation in the dependent variable. Since both the root mean square error and R-square values were so close in value for both the test and train set, the final model has the same predictive ability in sample and out of sample. As a result, the findings can be generalized. The final model had 5 independent variables. All of them are statistically significant at the 95% significance level because each of them had a p-value of less than 0.05. The regression estimates for the coefficient of percent population Black, percent population Latino, and traffic volume, annual vehicle miles traveled per square kilometer were positive. Therefore, higher rates of these independent variables are associated with higher pediatric emergency room visits. Percent population born outside the U.S. had a negative coefficient. A higher rate of this variable is associated with lower pediatric emergency room visits. PC1 was used to summarize housing conditions. This variable showed that worse housing conditions were associated with higher levels of pediatric emergency room visits. My hypothesis that higher pediatric asthma emergency room occurrences would be associated with poor housing quality, high percentage of Blacks in population, and higher traffic levels were all supported by the results. However, a higher percentage of adult smokers was not a strong predictor of pediatric asthma emergency room occurrences. The majority of the data for this project came from surveys that were conducted before the COVID-19 pandemic. If the pandemic had a long-term impact on some of the categories studied, the data may not be as predictive. Future research can be done to validate the model's predictability in other metropolitan areas in the United States, like Los Angeles, Chicago, or Boston. In addition, New York City is a highly urban setting. Since much of the country does not live in areas that are similar to New York City, future research could be performed to investigate asthma predictors at specific population levels in rural areas. Thank you.